And I would like to introduce Dr. Kneller.
Nice to be here, everybody, really. It's very nice to be here. Thank you for everyone coming out. It's flattering to have such a great crowd. I hope we have a good afternoon. I trust you'll find this very interesting, because I find it very interesting. I think it is very interesting. And if you have questions, interaction, we'll have probably 15, 20 minutes at the end to talk, but feel free to jump in when something comes up, and we'll just take your questions as we go along. So this is titled Understanding and Treating Heartbeat Irregularities. And this is my specialty, the electrical system of the heart. Our health and lifestyle goals. Why do patients come to see their doctors? We all have similar goals. People want to feel good. They want to look good. People would like to live as long as possible, and we're all fearful of the alternatives, which is pain and suffering, loss of function, and early death. So I begin with the assumption this is what's motivating us ultimately, and is what we really try to provide for people. And one thing that's exciting about our specialty, cardiology, and I think particularly electrophysiology, is that we can really help people achieve these goals, feel better, and that translates into living longer. We have good data for this. So what is possible in 2014? We know that the population over age 85 is in fact the fastest growing segment of the North American population, and there are in fact more centenarians, or people age greater than 100, alive today than in past centuries. So in general, it seems like health and healthcare is working for our society, and people are living to much older ages, and they're living well in older ages, and we want to get as many people there and support those goals as much as possible. So it's an exciting time to be in healthcare. And it's been a little bit of a hobby of mine to study centenarians to a certain degree. These are some people who have held world records for living the longest, age 122, age 113. And if you ask people who are living well at these very advanced ages, what's your secret to doing well? They'll tell you immunity to stress, a little bit of wine, olive oil, laughter, healthy diet, no cigarettes, milk every afternoon. Who's to argue with them? It's them who's 120 years old. So we think some of these things surely do work, and some of it's probably a little bit folklore, but we try to identify those things that do help people live well and really encourage those lifestyles. So this is a little bit from my family. This is a newspaper clipping of my uncle, Julius Kuhn, who lived to be age 103. And I see him as a good example of appropriate use of medical therapies. He lived well. He was very strong and this is him at his 103rd birthday party at his nursing home, where he spent his final year, and obviously he's still very high functioning. But through it, he had significant depression, Alzheimer's in later years, and also colon cancer, and he was operated twice for colon cancer in his 80s. Fortunately, we thought we might lose him, but he did very well through those procedures and regained his health and went on to do much better. So what I'd like to encourage all of us to do, and I think this population is best to do, is appropriate use of medical technologies. We want to live as healthfully as possible, avoid the medical system as much as we can, but when we need it, hopefully go there, have discrete interactions, and benefit. And that's my goal, and that's what I think is motivating the majority of our patients and probably this audience here today. So we can talk about heart disease. Heart disease is one of the major killers, conditions for early mortality in our population. And really how I think of the heart is that this is an organ that is a muscle. Its job is to pump blood. It's fed by its own arteries that give it its own blood supply to allow it to function. It's a system of valves which help the blood move through that pump and actually progress forward into your body. And then this muscle pump is in fact an electrically activated pump. So there's an electrical system that's causing all these things to work effectively. And of course, my specialty is in that electrical system, but we have to realize all the time that all of these components interact. If you have blockages in the arteries that feed the heart, they can block off. The heart that they feed can then die. That's a heart attack. dying represents loss of function. As the heart loses its function, its shape becomes distorted. The valves, therefore, don't align correctly. They begin to leak. All of these conduction abnormalities begin to develop. It takes a long time for the heartbeat to transmit across the organ. That can result in a number of problems. So we see how all of these systems are interrelated. And in any one patient, you try to find what's the root cause in this person and what's the simplest solution to address the real problem in this individual heart such that the entire organ starts to work more effectively. And therapies targeting the electrical system are becoming more and more understood and very exciting. So heart rhythm disorders, problems of the electrical system, what are classic symptoms? So we can have palpitations, that's the feeling that your heart is going fast or irregular, you're just aware of your heartbeat for whatever reason. Heart racing, you can have an irregular pulse, skip beats or pauses, you're not having a heartbeat for a certain amount of time. Patients can experience blackouts. There can be unexplained falls. You've fallen, you're not sure why you fell. And also weak heart muscle can be due to electrical causes and heart failure. And we can treat heart failure by addressing the electrical system in certain populations. So treatment of electrical problems, I really divide them into two broad categories: problems of the heart going too slow and problems of the heart going too fast. Often when the heart just goes too slow, your answer is a pacemaker, so you prevent it from going too slow and hopefully help somebody go as fast as they need to go when they're trying to exercise and exert themselves. When the heart goes too fast, that can be from dangerous rhythms in the bottom main pumping chambers of the heart. We call those a ventricular tachycardia or ventricular fibrillation, and often the therapy for those involves an implantable defibrillator. And I imagine there are several implantable defibrillators in the room today. Also, for those fast heart rhythms, we can offer therapies called ablation. This is where we put a catheter into your heart, following the blood vessels that go to your heart anyways, put catheters in your heart and use heat energy, cautery, to try to disrupt muscle fibers in a way that stops those fast heartbeats from taking place. And we'll talk about all of these things. So a very common question in this population is, do you need a pacemaker? Is your heart too slow? So what are symptoms from slow heartbeat? You can have near fainting or fainting. We call that syncope. Other symptoms could be dizziness, weakness, fatigue, shortness of breath, even chest pain. And people can be confused or have memory problems, mainly because they're not getting blood flow to their brain, primarily because the heart is just pumping too slowly. And also easy tiring during physical activity can be indicators for pacemakers. So let's talk about what a pacemaker involves. A pacemaker is a little unit that sits here just under your skin over your left chest muscle. Sits on top of the muscle, doesn't actually go into your body beyond that. And then through the veins of your arm that naturally flow into your heart, we can put wires. We call them leads. Those can stop in the top chamber or go across to the bottom chamber. This unit is very sophisticated. It senses if your heart is trying to beat, and if your heart beats on its own, it just watches you. But if that impulse doesn't come in time, it can supply that impulse and help you preserve a normal heart rhythm. That's the basic anatomy of a pacemaker. One of the great things about working in this field is that the technology is evolving rapidly at warp speed, so to speak. So the sophistication, the technology, the battery life in these units is getting progressively better and better and better, and it's a race even for us to keep up with it sometimes. All of this translating, of course, into better options for our patients. This is how that pacemaker would look on a chest x-ray. So we have the actual pacemaker sitting under the skin here, and then you can see the wires for that pacemaker passing through the veins in the heart. We've just drawn those on top of the x-ray so that you can see them, stopping in the top chamber, coming across the valve, and sitting in the bottom chamber. So that's a nice chest x-ray from somebody who's been implanted with a pacemaker. Typical cases, here's a 71-year-old female. She had aortic stenosis, which is a valve problem, underwent surgery for that. As a result, came out with disruption of her electrical system, was in complete heart block, and we implanted a pacemaker for her to address that electrical problem after she'd had surgery for a valve problem. So here's her pacemaker. Features I like is it sits nice and medial, so it's not interacting with her arm ever, and she'll be most unaware of it. And we see those wires flowing nicely into the heart, top and bottom chambers. it's a nice implant. Pacemakers are also heart monitors and can help us discover other electrical issues that people can have and are in fact bothering them. So here's a 90-year-old lady who had slow heartbeat. She was passing out. She had come into the emergency department for that cause. We had given her a pacemaker, and then later on she experienced similar symptoms. Now she felt her heart was racing and she was dizzy and she had low blood pressure. Called the emergency department again. The pacemaker documents, because it can record all of your normal, all of the heart activity that you're generating on your own, and we see this very fast rhythm for her. And we're able to then take her to our electrophysiology lab, put the catheters in her heart like we had discussed, and then ablate or cauterize that region of the heart muscle that's allowing her heart to support these rapid rhythms. The goal is cure, complete cure. And I saw her just several weeks ago, and she's doing better with her symptoms completely resolved. So there's somebody with a problem of slow heart rate, the solution for that, helping us diagnose fast heart rate and apply appropriate therapy to treat both of those conditions and make her feel better. Sometimes implants have their problems. Here is a 73-year-old lady who had a pacemaker back in February of 2012. And ever since her pacemaker implantation, her left arm was numb and had a tingling sensation. And we decided it was probably because her pacemaker was too lateral and actually pressing on the nerves that would go into her arm. So solution for that was to reoperate and to move that pacemaker much more to the midline so that it's not sitting on top of that nerve. And in fact, we did that for her, and the second it was completed, her arm numbness and symptoms went away. So good reason to have a quality implant in the first place, and be aware that when these things occur, we can help our patients get through them. So some celebrities with pacemakers. We don't know everyone who's had a pacemaker. In fact, Mother Teresa was implanted with a pacemaker. And so nobody's immune, and there's lots of room to benefit. So moving on a little bit, how about defibrillators? When your heart is going too fast. What are problems of hearts going too fast? This is a scenario where you have had a cardiac arrest, you've collapsed, it's been because your heart was going too fast. We had to shock you out of that rhythm, save your life. Or when you're at risk for having a very fast heart rhythm. And that's often the case after you've had a heart attack and the pump function of your heart is low. When the function of the heart is low, it's at risk for supporting dangerous rhythms, and we can recommend defibrillators to protect people from developing those rhythms when they have not ever had one previously. So the idea is very much like this. Here's someone with shocker pads to stop a fast heart rhythm. We can take this technology or this concept and very similar to a pacemaker, implant a defibrillator. Here this sits under the skin, very much like a pacemaker. It's a little bit bigger, and that lead goes in through the venous system into the heart. The technology here is able to detect those rapid rhythms, and should they occur, the capacitor charges up and can deliver a shock across the heart muscle just like this and reset that rapid rhythm back to normal. So here's an example of an implantable defibrillator. This is a 59-year-old male. He's a postal worker. He suffered a cardiac arrest. His wife actually had to do CPR, and we thought this might have been due to him applying testosterone patches to, we got to be careful about some of these things. And as a result, he had an arrest and deserved an implantable defibrillator. You can see this is a little bit bigger, still fits nicely in the midline so it's not bothering his arm. And then that single wire into the heart. And this time there's a thicker region. This is the shock coil. And should he need a defibrillator, a shock to restore his heart rhythm, that would occur between this battery area and this shock coil. So vector of electricity going through the heart resets that rhythm to normal. So that's, yes. Yeah, the shock is generally felt as, the shock is generally painful if you're still conscious at the time that the shock occurs. What we program the devices to do, if you have those rhythms, it'll try to pace you rapidly to try to interrupt that rhythm, and if it does, it doesn't have to shock you. That rapid pacing works frequently, and that is not painful. But then failing that, it would charge up and give the defibrillation energy. People describe that as being kicked by a horse. That's sort of worst case scenario. Then we meet a lot of people who say, It shocked me. I had no idea. So there's a bit of a spectrum. But we tell people that should this occur, and we hope that we're treating you in a way that it never needs to occur, but should it occur, we caution people that it's not going to be comfortable. So celebrities with defibrillators, I don't know if you'd call him a celebrity, but he's certainly a public figure. Dick Cheney, before he went on to a heart transplant, had been implanted with a defibrillator. Very interesting, as of this year, we have a much simpler way of providing a defibrillator to our patients. We now have a new technology which does not need to put wires into the heart at all. The entire unit can sit under your skin, so nothing goes deeper than your chest cavity, and we can provide someone with ICD protection using that. In that scenario, here is your battery computer here, and this lead is now coming on the outside of your heart and up the front of your heart, and that occurs in a way this device can still detect those fast rhythms and apply a shock along this vector through your heart muscle to restore you to normal. Our early results with this are really remarkable, and it's a way of not asking somebody to have hardware actually sitting inside of their heart. And that's appealing in many cases. It's brand new and something we're very excited about. Here's an example of that later technology. Now you can see on the x-ray that device is sitting on the side with that lead going up in front of the heart. So should they have an arrhythmia, the shock would go between this block and that shock coil, passing through the heart muscle, sets the rhythm back to normal. Along these lines, one more exciting extension of that technology for patients with heart failure, low pump function, long electrical delays in their heart muscle, so the whole pump activates slowly. I say one side of your heart gets the signal to start contracting way before the other side even knows to begin contracting, and as a result, the muscle's very uncoordinated and it can't recover. For those people who, in that circumstance, of course, deserve a defibrillator, we can also put this extra pacing lead on the lateral wall of the left ventricle. So now you have one on the right side, one on the left side. If we pace both sides simultaneously, you can synchronize the squeeze function of the heart. You can get immediate improvement in heart function, and that improvement can often allow the muscle to recover. So over time, we actually see those pump function indices improving. And this is really exciting therapy for our heart failure patients because people can feel better almost immediately, and it is certainly life prolonging. So that's the cardiac resynchronizing therapy, which is the most sophisticated extension of this technology. And we'll probably implant 4 of these at Kadlec already scheduled within the next 2 weeks. So a broad population. Finally, what about ablation therapy for the heart rhythms that are going too fast? To keep this talk a little bit simple, I'll just focus on the 2 rhythms which are the most common rhythms that we ablate. The first one is atrial flutter. It's actually our simplest. And the second one is atrial fibrillation. Large burden of atrial fibrillation in our population. So when do you offer someone an ablation therapy for their rhythm? First of all, if they're symptomatic, it really bothers them, and we're not controlling it with medications. So we're unable to slow it down with medications. We'll offer the ablation procedure, and that's also true for atrial fibrillation. So what does that involve? Here's your heart muscle, and this is a catheter that's come up from going in through your groin, up through the venous system. That catheter just snakes up like a fine tube of spaghetti, can sit in that right atrium, and there's a bridge of tissue in that atrium that supports your flutter rhythms, and applying heat energy with this cooling, you can see that it's irrigated. We can electrically disrupt that bridge of tissue so the heart can't support that flutter rhythm anymore. Goal is cure. Success rates are 95% and above. So a very common ablation, a common arrhythmia in our senior population, and very satisfying to perform because it is so successful and can alleviate patient symptoms. So that's our very simple ablation for atrial flutter. And here's what our environment looks like in the cath lab. Here's an ECG that shows atrial flutter. You can see these very fine flutter waves in between the larger spikes, which are the pump chamber activating. These are catheters in your heart on the x-ray. You can see we've positioned all of these spaghetti noodles throughout your heart so we can study the electrical patterns and then applying the ablation energy across that bridge of tissue to interrupt this rhythm. That's our work environment, what we're doing and thinking about while you're on the table. So atrial fibrillation, I know you know what atrial fibrillation is. It's becoming a 2.2 million people in the U.S. have atrial fibrillation. That's going to be 50 million by the year 2050. So this is a blossoming problem for us. Trouble is atrial fibrillation increases your risk of stroke by 5-fold. 36% of strokes for atrial fibrillation are in individuals 80 to 89, and strokes from atrial fibrillation are more disabling and more likely to recur or be fatal than strokes from other reasons. Atrial fibrillation can have bothersome to debilitating symptoms. You can develop heart failure because you have atrial fibrillation, and if you have heart failure, atrial fibrillation can only make it worse at times. So a real problem which is becoming the cornerstone of our practice. When you have been unsuccessfully treated with medications, we may well recommend an ablation procedure to you. In contrast to the flutter ablation, this is one of our most sophisticated procedures. And that is because catheters go into the right side of your heart very naturally. The fibrillation is coming from the left side of your heart. We actually have to cross the wall of your heart to get into that left side, perform extensive ablation in this chamber to rid you of your atrial fibrillation. And this becomes our work environment in the cath lab, where we have a patient under these drapes, a variety of cameras, electrical recordings that are helping us understand your fibrillation and completing the most successful ablation for you. But the question is, what does ablation mean? Ablation refers to that one catheter applying heat energy to disrupt muscle function. So it's that cautery energy applied from one of those catheters that is ablation. So most of these catheters we say are diagnostic. They just give us information. One of them can also perform ablation, which is that heat cautery energy. Yes, sir. Right. The question is, why is atrial fibrillation increasing? And it's mainly a function of the aging population. People are living longer. Atrial fibrillation, not exclusively, but majority is a disease of the elderly. So as that population expands, atrial fibrillation expands. I think also our awareness and our diagnostics are becoming much better. So the question is, what if you have a lot of slow heartbeat, but then also atrial fibrillation, but then your heart's going too fast? Often the slow heartbeat can limit the number of the types of medications we can use for the atrial fibrillation. But if your heart really is too fast on its own, maybe too slow on its own, you may need a pacemaker, and that's common for us. Then with the pacemaker in place to treat the slow rhythms or to prevent the slow rhythms, we can go after the atrial fibrillation. And that can be any of these therapies, medical therapy or even ablation. We perform a lot of ablation in patients who already have pacemakers or even defibrillators. That's a great question. One more. Yeah, exercise, meditation, healthful living to reduce arrhythmias certainly can be helpful. Certainly can be helpful. We talk about minimizing severe stress, maintaining low blood pressure, which can certainly exacerbate rhythms, and often meditating and exercise, especially cardiovascular exercise, is part of keeping your blood pressure down. So all of those things help, and they're good for you, help you live longer, do better. Frequently, they're not enough. Once you really have atrial fibrillation, it's become a problem for you. Yeah. But we'll always encourage that, and in many cases that's enough, or it's sufficient to at least delay therapy, hopefully on the order of years. Great question. There was one out here. Depending on the rhythm, ablations for atrial fibrillation we typically perform under general anesthesia, so you are truly asleep for the entire procedure. That one you couldn't watch. Other rhythms like the supraventricular, the rhythms from the top chamber, or premature ventricular contractions, their presence is really dependent on your state of arousal. So in that case, we need you to be awake to do the procedure, because we want to get these rhythms started up on our EP labs so that we can study them. And in those cases, we're frequently conversing through the entire case, and some patients are engaged in watching the monitors. Absolutely. So the question is, can atrial fibrillation that's not detected for a long time result in enlargement of your atrium, which is then a contraindication to ablation? It's true that if AFib goes undetected for a long time, your atria can dilate. Often atrial fibrillation occurs in atria that are already large. There's more substrate to support the rhythm. And in atria that are very big, we are reluctant to offer ablation because we think our chances of success in eliminating that rhythm are decreasing. Having said that, we'll certainly consider you, and I've ablated in very large atria before, and often it's a combination of ablation and antiarrhythmic therapy to completely eliminate your rhythm abnormalities or to minimize them and give you the highest quality of life. It's just that your chance of procedural success goes down as the atria get large. The question is, how does diagnosis of atrial fibrillation differ from an echocardiogram? So an echocardiogram is an ultrasound of your heart, just like an ultrasound of a baby. It shows you the heart, it shows you that the heart is moving, it allows you to assess the valves, assess the pump function, it gives you a picture of structure. That structure is happening because there's electrical activity. The electrical activity you can't see with the echo, so that becomes the electrical recordings. That's a great question. So I think what it is how does a maze procedure differ from this ablation procedure? So a maze procedure is something that cardiac surgeons can perform at a time when they have your heart open. Or your chest open. So they've opened your chest to perform bypass surgery or valve surgery, and at that time, from the surface of your heart, from that vantage point, they can perform an ablation for atrial fibrillation, and that's called a maze procedure. That's reserved for people who have another reason to have their chest open. For the majority of our AFib patients who don't have a need to have their chest open, the solution really is this ablation strategy, which is an endocardial ablation. So now we're doing the ablation from the inside of the heart muscle, whereas the surgeons with the maze procedure are doing it from the outside of the heart muscle at a time when they have access to the surface. Similar effectiveness in terms of eliminating AFib. Really great question. So we'll just clip along through a few more of these. If you have an ablation for atrial fibrillation, you come to our clinic, we've decided this is something that's best for you, we're going to offer this to you, prepare you. What's that sequence like? One of the first things we do is we do a CT scan of your left atrium because we want to know the exact size and shape of your left atrium as part of our procedure planning. So you get a CT scan, and these are what the images look like. This is your chest wall with your heart inside, and we will actually start to take apart that image to clip away the other structures until what we've isolated here is your left atrium. That's the chamber where atrial fibrillation most comes from, and we can see those pulmonary veins inserting into the atrium. And we know those pulmonary veins are really the jet engines of activity that drive the atrial fibrillation, and our ablation strategy is going to be targeting these veins. So then using this image, we can actually bring that image into our procedure to guide us while we're moving catheters in your heart to get the best result for you. So as before, now you're in the procedure lab. This is under general anesthesia. So the first thing you know is you go to sleep. The next thing you know is that it's over. In the meantime, you've been in an environment like this. The patient's under the table here. We have X-ray cameras positioned here. On our computer screens, we have echo cameras, mapping cameras. We have the electrical recordings. All this information to accomplish the best result for you. And of course, there's the operator standing there. Procedure takes 4 to 6 hours, depending. So we typically say one night overnight after the procedure, we expect you to walk out of hospital the next day. So that's sort of what you're preparing for. Come in the day of, walk out of hospital the next morning. In the meantime, all of this has taken place. Again, what does our work environment look like? We're going into the hearts with catheters. Every time the catheter moves in your heart, a computer makes a recording of where that catheter has been, and we draw these maps. Here's your right atrium. This is your vein up to your head. This is the vein from your lower body. We've crossed the wall of your heart into this chamber, which is your left atrium. We move the catheter to define that chamber, and everywhere where you see a red dot is where we've applied ablation energy to target where the rhythm's coming from in that individual's heart. When that's all done, catheters come out, extubate the patient, spend the night overnight. We expect you to walk out the next morning. But a very sophisticated, high-tech procedure environment during that case. And it's exciting to be a part of it because this sort of technology is what's moving just so quickly, and it's improving on a yearly basis. And we have the very latest at Kadlec. Believe me, they purchased the latest equipment, and it's fun just to be in that environment. We talked about monitoring for arrhythmias. How do you know if you're having one? Or how do you know if our therapy for your atrial fibrillation is actually making progress in you? I thought I'd touch on this business of continuous monitoring for arrhythmias. We said the external monitor is up to 30 days. You can wear one. Hopefully we get the information we need in 30 days. If we need longer monitoring, this is an implantable monitor. Sits under your skin, right over your chest muscle. Nothing goes into your body. It can sense every beat of your heart. Battery is good for 3 years. It'll record a bunch of stuff automatically. You don't have to do anything. If you want to tell the device that you're having symptoms, you can click on it with a wand and it'll record everything that's going on at the time that you feel unwell. And we'll have that information. So this is about the size of a USB stick, and that's a little scar in this patient where that monitor implant was, and it's sitting right like this. As of yesterday, the FDA approved the sequel to this monitor. If that's the size of a USB stick, the new monitor, which is even better than this, is the size of a match. It's really cool. And that came out yesterday. We'll probably implant our first one at Kadlec 2 weeks from now. So there's technology moving at warp speed. This is the kind of information that we would get from the monitor. We could say in this person, AFib is 35% of the time. When the patient's in atrial fibrillation, this is how fast the heart rate is going on average. This confirms that it truly is atrial fibrillation, that irregular activation sequence. And in this person, we could see that the majority of the episodes started at, what time is that? 9 o'clock. And the patient said, you know what? 9 o'clock is the time when I just start to fade. Couldn't tell for sure whether he was going in and out of atrial fibrillation. The monitor could say 40% of the time your episodes are starting at 9 o'clock at night. And the wife and the patient could both say, yep, that's the time when the symptoms really start. Can't feel the irregular rhythm, but I just fade. The fatigue starts to set in quickly at that time. That helped us understand that this was a symptomatic rhythm, that advanced therapy could benefit this person, offer them ablation, and this is a much happier picture. Almost completely eliminated atrial fibrillation in this gentleman. So that's my formal presentation. Great, we've had lots of questions already. We've got a brand new electrophysiology lab at Kadlec. I'm happy to say I relocated to the Tri-Cities. Some of my best lab staff from Spokane relocated with me. And we have a very mature operation, right starting immediately at our hospital. So we're very excited. And I have several of my patients here. Be happy to see anyone who feels they need to be seen by electrophysiology, either starting from their cardiologist or primary doctor or just calling our office and making an appointment. So this is my scheduler's number if you want to call our office directly. Ask your doctor for a referral. We're located at 1100 Goethals Drive. And that's my website if you want to read a little bit more about this stuff. Lots of questions, and we're time is short. So let's start in the front and work back. Question is, can you take the monitor out after the ablation? You absolutely can take the monitor out. I would encourage people to keep it in for the duration of the battery. It helps us monitor for recurrences and what to do in the event of recurrences. But absolutely, when we're done with the monitor, it comes out and nothing is left in your body. And there's nothing stopping us from taking it out at any time. What is the battery life of an ICD? So again, battery life is rapidly evolving. The best batteries right now, 10 years. Depends on the device. It depends on how much therapy you get, because therapy requires battery. So if the device is delivering therapies, that's going to drain the battery. If the device is also pacing you, that's going to drain the battery. So it depends on the individual. But for the device just to sit in your body, maintain itself over its lifespan, 10 years is what we're expecting. I would be very disappointed if any ICD got less than 5. That's a great question. Is the cost of the procedure insurance coverage and Medicare? We have ablated many Medicare patients. Questions of copay, things of that nature, I'm never sure of. It seems like it's always changing. But for appropriate patients, Medicare has not withheld. How bad does atrial fibrillation have to get before we treat it aggressively? If your palpitations bother you, to me that's a sufficient symptom to offer ablation if we've at least given medical therapy a chance and proven that it's not satisfying. I also take symptoms of just profound fatigue as seriously. So a classic story is I have atrial fibrillation. I used to feel heart racing and palpitations. Now I don't feel anything. I'm just tired all the time. I take those symptoms of being tired all the time as seriously as the palpitations, and this thing is driving me crazy. And treatment for atrial fibrillation can improve both of those. Why do you need to be intubated during ablation? It's a long procedure, and we need to keep you really still. So we use general anesthesia partly just to control the environment. Have you perfectly still for hours in duration so we can do the work we need to do without you being uncomfortable or without you moving in a way that could be dangerous to our procedure. There are certainly centers that do ablation for atrial fibrillation without general anesthesia, and I was trained in some of those centers to do that procedure that way as well. Right now it's a preference choice from our standpoint to do it with general anesthesia, but you don't absolutely have to. Am I personally involved in prescribing medicine, or do I just wait till someone else has done it? I personally prescribe medication, and I personally adjust medical therapy for atrial fibrillation. Often I'll get someone who's already been on several things and it hasn't worked, and people are wondering if we should move on or try other options, because I probably have more options in my mind than most docs, because this is my area, but I absolutely do that myself. On the defibrillator, how do you recharge the battery? Say on a pacemaker defibrillator? You do not recharge the battery. It's a surgery to take out that unit, the computer and the battery, and to put in a new one. Yeah, without putting the wires into the heart. Those are still good, they just sit there, but we have to replace this unit. So the unit you get has a better battery than the one you had, so you may not want to recharge it, and usually the sophistication of the device has increased substantially, so you get more benefit from it. So it's not a bad deal, but right now it does involve another surgery. So the question is, ablation implies removal of tissue. Are you actually burning something? We are actually burning something. It's heat energy, it's cautery. I don't use the word burn. I say we're disrupting the electrical function of that heart muscle, but it's true, the heart muscle is getting burned, and that's why it's disrupted. Again, then we talk about how much do you need to be effective? We're not destroying large regions of heart muscle. Usually it's very discrete areas that are problematic in a way that would not compromise pump function of the heart. How does the occasional skipped heartbeat fit in with this? Skipped heartbeats occur. It can be a problem for you. It may not be a problem for you. It depends on the source of that and how much it bothers you as to how aggressively we would go after it. They can come from the top chamber or the bottom chamber. Sometimes those extra beats are things we'll perform ablation therapy for or drug therapy for. Again, it really becomes a question of how much does it bother you, and is it having an adverse effect on your overall heart function? So that's something to consider individually. But a lot of people have extra beats and there's no point in treating them. How does a heart murmur fit into all this? So a heart murmur is typically a valve problem. That's blood flowing across a valve when it shouldn't be flowing across a valve. Either the valve is supposed to be shut, but it's not shut completely, so the valve leaks while the heart's contracting. That causes a murmur. That's the sound of the abnormal blood flow. Again, there can be physiologic murmurs. Not every murmur is a pathology or a problem. You know, the heart valve shouldn't be completely tight, and it's a question of, is the blood flow causing the murmur significant enough or representative of pathology, and then what to do in any one person. So does valve problems lead to electrical problems? Yes, they do. So say you have a leaky mitral valve, so every time your heart gives its big powerful contraction, a big whoosh of blood goes backwards into the atrium. As a result of that happening every beat of your heart, the atria tend to enlarge and they tend to fibrose. That becomes a substrate for atrial fibrillation. Then the atrial arrhythmias begin to occur. So there's a valve problem leading to an electrical problem. So fixing the valve problem early might have prevented the electrical problem. Now that you have both, fixing the valve problem would improve the electrical problem, and it's a question of whether it's enough to say that's no longer, an issue for you. Those are all really great questions. We had one hand here. What is atrial tachycardia? That is a more generic term for any fast rhythm in the top chamber of your heart. What it really probably refers to is one little spot in your heart beating really fast. So there's one little place that's going really fast, and that's taken over from your normal heart function. So it's a little bit different from fibrillation. It's a little bit different from flutter. We give the same therapy for atrial tachycardias. If you can find that one spot with a catheter and ablate that one spot, you can eliminate atrial tachycardias. They're just not as common, so I didn't focus on it today. It's about 5% of difficult rhythms from your top chambers is that mechanism. Alcohol for atrial fibrillation. So there's this whole hypothesis that red wine is healthy for your heart, and it may reduce your incidence of atrial fibrillation. That's probably because the alcohol helps you relax and have a lifestyle where you're relaxing, and decompressing your stress. There's another syndrome called the holiday heart syndrome, where people who binge drink on the holidays end up in the emergency room with atrial fibrillation. Sure. I don't know who's next anymore. I'll just take hands. So the question is, Xarelto is on anticoagulation for atrial fibrillation. We know you need blood thinners to prevent you from having clots. Before, the only drug available was Coumadin or warfarin. And for those of you who have been on it, you have the monitoring issues. And if it's, your diet can influence Coumadin, things of that nature. We now have these new oral anticoagulants like Xarelto, also Eliquis and Pradaxa. The question's about Xarelto. Is it more dangerous than Coumadin? I would say it is safer than Coumadin because your blood level of anticoagulation is much more stable. It's safer than Coumadin because it is also reversible, meaning that if you have a serious bleed on Coumadin, if you come to the emergency room, we can reverse it faster than we can Coumadin. So we can get rid of that anticoagulation effect. So it's safer in the event of a disaster, and it's safer in that your blood level is more stable. It's less safe in that if you miss a dose, you're not anticoagulated. Whereas with warfarin, if you miss a dose for whatever reason, your anticoagulation level would just dip a little bit, but you wouldn't be left unprotected. The question's about aspirin therapy and whether it's effective. It certainly can be effective. Is aspirin therapy enough? Not for everybody, and not all the time. So it's something to evaluate individually. So the question is, can a pacemaker adequately monitor for atrial fibrillation? And if that pacemaker has a lead in your top chamber, which most of them do, then it is an adequate monitor for atrial fibrillation. And it should tell you everything, about your AFib. Right, so I think the question's about a schwannoma, tumors in the heart that can be discovered incidentally, is the question. And it sounds like an incidental discovery of a heart tumor, most of which are completely benign. They just grew there, but it's not like you have cancer and this thing's going to kill you. That's usually the case. It depends on, of course, the individual and what exactly that circumstance was, but usually they're safe. Take this one. Okay, so the device they use was what again? Okay, so the question is would a 24-channel ECG be better than a conventional 12-lead ECG? There's certainly indications where a 24-lead ECG would give you more information than a 12-lead ECG. So it would depend on the circumstance. I'll have to say we don't use them very often. So the question is, would that more advanced ECG give you better localization to plan your ablation? Probably in certain circumstances it can. I tend to think we can get most of what we need from a 12-lead ECG, and fine-tuning that really can only occur effectively with catheters in the heart, when you can start to really zoom in on things. But there may be some incremental benefit to higher resolution ECGs. My perspective, that's my take on it. Right. The question is atrial fibrillation. Gentleman takes a medication called Rhythmol, which is also propafenone, and takes a dose when he gets the episode, hoping it'll stop the episode, and wondering when the episode doesn't stop and he's taken another one, at what stage should he go to the emergency department? So that's something to plan with the person who's prescribing that for you. It's certainly an acceptable strategy for atrial fibrillation. We call it the pill in the pocket strategy, meaning you have infrequent episodes, and when you do get one, you just take one dose of a med and hopefully it stops. In my experience, like yours, it usually takes several hours for that to stop the arrhythmia. And if it doesn't stop it and it's bothering you enough, I agree the thing to do, if it's bothersome enough for you, is to go into the emergency department. You know, I would say who's ever prescribed that for you should sort of talk through what your strategy is going to be. Like if it doesn't work for you in X number of hours, what are you going to do next? You know, and that would depend on knowing about your heart. But it's certainly an acceptable strategy. So the question is, can a diagnosis of postural orthostatic hypotension be related to a heart problem? It certainly can be related to a heart problem. This is something that we talk about. It's really a problem of your autonomic nervous system. So your balance between your fight response from a nervous level. And there can kind of be two components of that. There can be, you get a nervous imbalance. One of your responses can be inhibition of your heartbeat, so your heart goes really slow. The other response is your blood vessels dilate, and so your blood pressure drops. So one of those two. And to the degree, if it's very profound cardiac inhibitory, a pacemaker can actually help in those cases. Usually it's more related to the blood vessels in your legs, and you know, heart therapies can't help in that circumstance. So it really is evaluating you individually and trying to find out what's the major mechanism in you, and offering a solution that's targeting your specific problem, because there's a range. Sir. So the question is, why can't the new anticoagulants for warfarin not be used in the case of artificial heart valves? And the answer is that they have never been studied in the presence of artificial heart valves. So they're all brand new, and all the studies that evaluated them excluded people with heart valves. So just because they haven't been studied in that population, we're not given the green light to prescribe them in that population. Although we may find in the future that they're perfectly acceptable in the presence of heart valves. They just haven't been evaluated yet in that circumstance. Sir, can you have atrial fibrillation and not be aware of it? Absolutely. You may not have any symptoms at all, and you can have it. And if you have it, the stroke risk from atrial fibrillation is still there. So this gets into this business of cryptogenic stroke, which is a neurology problem. Someone comes in with a stroke, you do the full workup, you can't find any reason why. We start to wonder if there's undiagnosed atrial fibrillation that person's having. And maybe that's the reason. So it is absolutely possible to have completely asymptomatic atrial fibrillation and still be at risk because of that. So the question is, what are symptoms of atrial fibrillation? What does it feel like? So there's a spectrum, and everyone's different. What often will be described is the feeling of a fast heartbeat, or you can feel the irregularity, your heart sort of stuttering as it beats. People will use the term, I just feel out of rhythm, meaning they can just tell that things aren't coordinated the way they should be. Those symptoms are great. Some people will feel those. Often that becomes a picture where someone feels fatigue. They're like, I just feel tired, I feel short of breath, I can't exercise as much, and I think it's because of my atrial fibrillation. So that can become a symptom. Do you know, I mean, we're all tired all the time, right? But so is that because of atrial fibrillation? I know in me it's not, but in some people it really is. And if you can address it, you can take away that superimposed level of fatigue, which is from the arrhythmia. So that makes to answer your question, that makes the symptom spectrum really broad. And some people may feel neither of those. They don't feel the palpitations, the irregularity, and they're not that tired. You know, nevertheless, AFib is there. It's really just so much variability. All those scenarios are possible, and it's really about trying to figure out what it is for you. So the question is, this lady has a pacemaker, and she's been diagnosed as being in constant AFib. should she seek more help? It's an individual decision. You're probably on a blood thinner because you need to be protected from stroke that could be due to atrial fibrillation. What that pacemaker will tell you is the entire range of heart rates that you experience, and hopefully those are what we call physiologic, meaning they're appropriate for you. When atrial fibrillation is in a form where it's permanent, it can be really hard to get rid of it. So the more atrial fibrillation comes and goes, the more vulnerable it is to termination and the more our therapies are successful. When yours is there all the time, and if that's really the case, it can be difficult to treat. That being said, if we decide you're having symptoms that are really due to that rhythm, it can be worth being aggressive, trying different medical therapies, trying to interrupt that rhythm, possibly offering you ablation. You know, I don't rule it out. I've been sent people who are truly symptomatic and in AFib 100% of the time, and we've offered them ablation therapy, and that in combination with medication has completely eliminated it, and they feel better. So it becomes an individual decision, and that's what we're dealing with. The likelihood that AFib's harder to treat because it's permanent, and then how much is it actually bothering you? And that requires a conversation with you in detail. Yeah, the question is, what is the role of electrolytes in arrhythmias? And can imbalances cause arrhythmias? I would say the heart's very sensitive to the levels of your electrolytes, and typically high levels are more stabilizing, particularly potassium and magnesium. So you should have good levels of potassium and magnesium. That tends to make your heart electrically stable. Is that enough to get rid of rhythms? It certainly can be. Stabilize them satisfactorily. Other times it's not, and it's more than electrolytes. But probably one of the first things to check in anyone presenting with a rhythm is what is the status of their electrolytes, and are they topped up, so to speak, you know? Or is there obviously deficiencies that should be addressed before we do anything else? So the question is, can low levels of electrolytes affect your heart after a while? So the heart's an electrical organ. The muscles are an electrical organ, requires certain levels of electrolytes to function efficiently. You should be within normal ranges, absolutely. And there are conditions where people waste potassium or they waste magnesium, and that can cause electrical disturbances and can weaken your heart muscle. So it's definitely something to be aware of. Can you get too much potassium in your system? Yes, you can. You can get too much potassium, and high levels of potassium are lethal. Something to be aware of if you're taking potassium supplements. It's just something to be aware of, that's a possibility. And often it's a balance between diuretics and supplements to find the best level for you. But it's absolutely possible to have too much potassium and have cardiac arrest from too much potassium. Magnesium, question is, what about magnesium? I'd say magnesium is much safer. So the question is, he had an episode of pericarditis, which is inflammation of the heart muscle that can cause pain. Therapy for that was with aspirin, high doses of aspirin, which can treat the inflammation, but in the setting of high doses of aspirin and with the platelet inhibition from high doses of aspirin, he developed bleeding in his esophagus, which was probably predisposed to some bleeding, but that was enough for the tipping point, and it was severe enough that he needed blood transfusions. What to do if pericarditis returns? I think that history is very important. There's agents to treat pericarditis like colchicine, which does not have any blood thinning effects. And I would probably try to make that the cornerstone of what you had. Also, other non-steroidals like aspirin, but don't inhibit platelets like aspirin would be the way to go. Even ibuprofen. Why not ibuprofen? Doesn't inhibit platelets and it can treat pericarditis. So I think knowing that was in your history, if it happened again, we would just try to stay away from anything that had blood thinning properties.